Hello, everyone. Welcome to Health IT Matters. This is a podcast in which we explore the ways health information technology is transforming healthcare locally in Florida and on a national level. Health IT Matters will be held on the third Thursday of each month and will explore the many facets of the ever-growing health IT spectrum. I'm your hostess, Corinne Slaughterback. I'd like to first introduce Pam King and Kim Davis-Allen, who will be leading our discussion today. Pam King is the HIT Outreach Coordinator at the Agency for Healthcare Administration, and Kim Davis-Allen is the Outreach Coordinator for Florida's EHR Incentive Program. In today's episode, Pam and Kim will be talking with Michael Craig, the HMS Project Manager for the Florida Department of Health. Michael has been managing complex software development and systems integration projects for over 20 years and is currently managing the Department of Health's many electronic health record, practice management, and enterprise initiatives. Today we will be learning about health IT initiatives that the Department of Health is utilizing to improve public health.
Thank you, Corinne. We are going to be looking at all kinds of health IT initiatives here in Florida and how it impacts us here in Florida. And I'm really super excited about this episode because we're going to be talking with Michael Craig with the Department of Health.
So yes, and I think the Department of Health is such an underpinning to healthcare delivery throughout the state. So it's really exciting. And thank you, Michael, for taking the time today. And we just want to kind of just jump right in. Thank you, Michael. I don't know if you want to do any more introductions of yourself. It sounds like you've got a lot of really good experience to kind of help you in your current role. So let's just kind of start out a little bit about, for those who may not know, when we talk about Florida Health, kind of tell us what that is. I mean, I know it's more than just the health departments.
Sure. Thanks for having me today. Florida Health really is like the brand name of the Florida Department of Health. And it represents the vision that health belongs to everyone and every group, and not just the specific state agency. We may be a little bit bigger than some people even can wrap their heads around, because DOH, of course, we have our central office, which is the state health office here in Tallahassee, that does have statewide responsibilities for oversight. But there's 67 county health departments, there's 22 children medical services offices, 12 medical quality assurance regional offices, there's 9 offices for disability determination, and there's also 3 of our public health laboratories where we actually do the lab test resulting there. And that, for those 67 county health departments, that represents a total of 255 sites across the state. And they provide a variety of services ranging from, small to large in location size. As they say, if you visited one county health department, you visited one county health department. And I think that what they're implying there is that each of the county health departments is specifically tailored to the needs of their local area. So what's a need in Miami is not necessarily in need of Pensacola. And because of that, their operations are slightly different.
I don't think I even had an idea of just how big all of those different areas were. So at the 12 medical quality assurance, I don't think I knew about that. So that's great. Pam, did you have a question?
As you talked about the county health departments and how they vary from county to county, it had got me thinking about county health departments have really changed over the last couple of decades. Not that, you've been around that long. I know you're a young man. Some of us have been around a little longer, but how technology is impacting the county health departments in different ways. Maybe some examples of how technology is being used by the county health departments.
Even foundational to that, just maybe some of the services, because like you said, you've gone to one county health department, you've gone to one, so right. Maybe kind of pulling all together.
In a lot of ways, the role of Florida Health has changed too. Which is driving some of that IT. There certainly was a time when, Florida Health delivered a lot more primary care than it does now. Now there are still a few CHDs that provide that comprehensive care. And as an agent of public health, our services are often seen as a slice of the pie that's not addressed by other community partners. immunizations and family planning services, those are certainly high on the list of services we provide, but we also focus on addressing conditions of public health significance. By that I mean STD care, treating and preventing HIV, the work we do with the WIC program, and also like tuberculosis care, for example. And when you look at that as far as how technology has been able to be used to help navigate some of those changes, our first major hurdle was modernizing the tools available to our clinicians in the CHDs. That modernization began with development of an electronic health record and migration away from the paper-based record keeping. I know when I started, we were just, and that was about 10 years ago, I started with the Department of Health. We had just begun transitioning away from paper records and looking at the electronic at that time. We saw EHR certification as really a baseline standard for an EHR. So we went ahead and we achieved that ONC certification back in 2012, and we've kept it up through two additional rounds of certification. Excuse me. So now that we're consistently collecting that data in that standard electronic format, the focus has really changed to how can we now be interoperable with the larger health ecosystem. And so that's one of the reasons that we're currently undertaking an effort to connect the each EHR to the nationwide Ehealth Exchange through the Florida HIE.
Oh, so you mentioned the interoperability, and I know the county health departments are using some of the Florida HIE services. So how has it been that whole 10 years that Florida Health has been working with the Florida HIE, and what has that relationship been like?
Yeah, it's actually been longer than that. Our relationship with that, it predates my role as the EHR project manager. I was with the Department of Health previously, which was right about when the initial partnership started. Because we began looking with ACA at the idea of Florida HIE back in, I think it was 2008 or 2009. And it's funny because at that time, the struggle was data ownership and working to convince organizations that a patient's medical record was not their intellectual property. But now, as you can expect, the landscape's really, really different. Patients expect hassle-free electronic access, and they make that expectation clear. So the landscape really has changed over these 11 to 12 years, to where what was once someone's idea that was heavily criticized is now an expectation. And everyone in the industry now has that expectation that, no, that's my medical record and I can have it anytime I want it. And in fact, if I tell you I want you to send it over to this other provider, I'm going to expect that you're going to do that in a reasonable amount of time.
Yeah, it is really interesting how that has changed over time. Even, I mean, it's really kind of a short stance of time that the thought process has changed and has evolved. And I was listening to a conversation the other day about, wow, we're talking about interoperability and people aren't rolling their eyes and yawning. There's a real interest in that, and how are we going to get to that next step of making it seamless, right? That interoperability seamless. So it's really exciting to hear about Florida Health being kind of on the forefront of that and making that happen. And I know you guys are working on a lot of other health IT initiatives as well as interoperability. So what are some of those health IT initiatives you guys have been working on over the last decade there?
Yeah, well, I mentioned a moment ago about building and certifying the EHR, and that has really opened the door to numerous IT initiatives. Now we have electronic data in a standard format, so it's almost like the entry requirements to play the game. And as our user community sees this EHR as built by public health professionals for public health professionals, it certainly is. Once we completed that initial certification, we undertook projects to develop templates within the application to sort of guide the administration of public health services in a consistent manner. If you're doing things consistently and recording data about it, you can monitor it, you can measure it, and you can put in initiatives to improve it over time. And that standardization of data collection has really allowed us to develop program-based metrics that improve the quality of care. And I'd say the biggest initiative we have going now, though, is integration with the Florida HIE, and making use of all the services available through the Florida HIE. Last fall, as you know, we undertook the encounter notification service and implementation of that. That went relatively quickly for what needed to be done, surprising to myself, just because usually technical projects have lots of hurdles, but the ENS implementation was relatively hassle-free from our perspective. It was easy comparatively. Now, the harder part of the project is connecting to the nationwide networks in the Ehealth Exchange through the Florida HIE. And that's what we're doing right now. We're actually testing our connection to the Florida HIE, or the Ehealth Exchange, through the Florida HIE now. We imagine we'll be able to begin sharing clinical data out to our partners through the exchange within about 3 to 4 months. And then we'll be able to consume data over the exchange a month or two after that. Of course, our division within DOH is not the only group at IT that's pursuing, health IT initiatives, and it would be unfair of me not to mention some of those. Over the same time period that we've been working with ACA, the department created the prescription drug monitoring program, and that goal was to make that essential data available when appropriate. So the program is moving to increase access now, though, because just similar to the electronic records, when the PDNP first came out, it was very restricted as to who could use that data and for what purposes. I know at the time we were first on board and said, hey, let's integrate it with the EHR, and it's a Department of Health system. That way we've all have the access to the data. It was like, no, not just yet. We're not quite ready for that. And I think that's exactly what it was, and I'm saying we're not quite ready for that. That wasn't the department saying, and I think that was more just, industry in general, because that data was so sensitive. It wasn't something that they wanted to fall into the wrong hands. And certainly they wanted to have a little bit more control over it than just putting it into the EHR, which then it becomes accessible as all the parts of the medical record. But like I said, they're moving to increase the access to that data and make it more available at the point of care. Things like integrating that in with e-prescribing workflows, so that you can use that for the DOR checking that needs to be done, using a patient's current medications that they're taking, and then applying to it what you're about to prescribe and determining if there's going to be any contraindications or anything. Also, probably another really big one, big program that's been working with Health IT, that is, would be Florida Shots. And they've undergone significant changes to comply with then the meaningful use program, where meaningful use required providers to submit immunization data to the department. Well, in general, our providers were using Florida Shots, and they were logging directly into Florida Shots. They were getting the information they needed, and then they were entering the shot data right into Florida Shots, and everything was working well. Well, the greater health IT goals were a little bit different than that. And they really wanted, that function to be more in the EHR. So the EHR does the work of looking at what needs to be prescribed and then submits what was prescribed off to Florida Shots. So to do that, they needed to make that forecast and history information consumable by EHRs. And they've done that, in a real-time manner. There's hundreds now that are connected to Florida Shots and able to consume that data. And then, it's a two-way street where they're able to submit their data back electronically to Florida Shots in compliance with the promoting interoperability objectives now.
I just have a couple of things, and that as you were talking. So Pam, you might want to just, for those people who don't even know what our encounter notification service is, you might be able to just kind of get that highlight. But I was really excited to hear about the Ehealth Exchange, because as a county health department and all these other programs that y'all are running, there's such a need to share information with community partners, because there's not like one central place that everybody gets care. So, so kind of, I don't know if you want to talk a little bit more about that, about the plans for that and how y'all are kind of rolling that out. But encounter notification is such an important part of the Florida HIE.
Well, Michael, do you want to kind of talk about and really kind of that national connection too? What does that mean, and what will that allow the county health departments do with that connection to the national exchange? And then also the encounter notification service, which is ENS. What does that provide the county health departments? And I know you are both a sharing data or able to share data as well as receive data. So what does that look like from the outside for those that don't know what those programs are?
Certainly. Well, it's based, the ENS system, it allows us to create a panel of our patients. And then anytime our patients are seen at one of the over 400 other participants in the ENS service, we get a notification through an electronic system that says, hey, your patient was seen at this location, and we get some information about that visit that they had. That, by itself, it's a piece. It's a piece of the puzzle. And for the Department of Health, of course, we have needs that are our own and interests that are our own here at the Department of Health, but then we also have needs for being a good participant in the ecosystem, as we say. So I'll focus on our needs first, of course.
We would expect nothing less, Michael, nothing less.
No, of course not. The ENS service, coupled with the ability to go out there and query the Ehealth Exchange, those two services are going to work hand in hand for us, and they're going to do something that we've really never been able to do. Our EHR is a distributed system. It's managed locally by each of the CHDs, although it's the same software, same database scheme and everything like that. They are siloed, so to speak. Now, once we have this ENS, being that we're a subscriber and a data source, what's going to end up happening is that if one of our patients receives a service at a county health department and then goes to another county health department to receive a service, the first county health department is going to be notified and say, hey, your patient's been seen over at this location. And then we can turn right around and say, oh, okay, well, let me get some information about that visit. So we can go out there and retrieve a clinical summary for that visit that they had at the hospital or another provider within the network or anything like that. So that really closes a loop for us, because we do have certain programs at CHDs where one CHD will host it. However, there's clients that do get services from other CHDs, but maybe their home CHD doesn't offer that service, so they need to get it over here. So we've always had a challenge with moving records back and forth between the CHDs. Certainly when we first implemented Direct, that was seen as, well, wait, here's a great way that we can communicate between CHDs and share data. It's a little bit more work than what we'd initially anticipated. Certainly the solutions that we're talking about now are, a lot less work to get the information, so to speak. I can go out in real time and I can retrieve a clinical summary, as opposed to sending off a direct message to a provider and hoping that they see it, hoping that they know what I'm asking for, and hoping that they give me a CCD that I can actually consume in my EHR, because that's not a guarantee even if you're certified these days. So, that's more of our focus on ourselves. But yeah, we do operate as a piece of that pie. And so the visits that they may get at a county health department, it may only represent one small slice of their care, but in a lot of cases, it's essential. They come to the county health department for things that possibly they don't want their primary care provider to be aware of, but things that are essential to be known, because the conditions that you have and you're seeing the county health department for, they're important in other medical settings as well. And so we're really going to be able to open ourselves up and our medical records to everybody else in this case. I know there wasn't a lot of consumption of us from the ENS perspective, but I think once we make our data repository and our host of clinical summaries available, there's a lot more value to our community partners to come in and consume the data from the Department of Health.
That is so important, because you're right. I mean, the data that you have is very relevant in certain situations. So that's exciting. So I was going to say, it sounds like it was a pretty easy transition or implementation, I guess is the right word for that.
It's easier than initially anticipated. We've got some good vendors in the mix, and I think more than anything else, I think the tools that we're using now have matured. We have tried this in the past, and previous explorations required us to be much more intimate with the nuances of the software to be able to do the integration. Whereas now it's a little bit more plug and play, and we've abstracted ourselves from having to be the managers of the software and learn each of these other applications and how they're going to work with our EHR tool. And now we're consuming this as a service rather than having to learn all of that ourselves. We're working with vendors who just provide us the service of a master patient index rather than having to go in there and really be experts in a master patient index.
Yeah, that's a really important point in general around health information technology. We've come a long way with the development of off-the-shelf services and products that can be used that really, provide an opportunity for providers maybe that are smaller to be able to implement some solutions. And just your experience in that realm from just the last 10 years or so shows that. So that's a really important point. Thank you, Michael.
And I think maturity is right, is that not only has the technology matured, I think the policy has matured, but I think what's really important, you said it earlier, with patient expectations have matured, especially over the last year or so.
Yes, I think all three of those things have worked together to sort of put us where we are right now.
So I know you talked a little bit about PDMP and Florida Shots, but I know there's some other services maybe that the health department is using, Florida Health is using, maybe some syndromic surveillance, EMS services. You want to talk about any of those, or?
Sure. Yeah, my focus is the EHR, but the department's much larger than I have to come to that realization sometimes. And these Florida Health or Florida HIE services that are being available, it's really interesting. ENS is a perfect case of how the department has found ways to utilize ENS to support its various programs, and we're not all using it in the same way. So it's something that's versatile enough that we can fit it into the various workflows. I know CMS, Children's Medical Services, they're an ENS subscriber. And they receive ENS emergency room and hospital discharge alerts for patients who are children who are in the CMS managed care plan. And that just helps support that continuum of care for them. The emergency medical oversight program is another ENS participant. Now, they're participating as both a subscriber and a data source. So they're receiving emergency room encounter information for these patients who've been transported by local emergency responders, and those outcomes get used to evaluate and improve those emergency response services. But then as a data source, they provide emergency response incident information back to the ENS service so that subscribers can leverage that to initiate patient outreach when necessary. So really, being proactive that, hey, I see this has happened, you need to come in for a follow-up, things like that. Now, the EHR and the CHDs probably will be using that in a similar way to sort of initiate that patient outreach of, hey, I saw that this incident happened, you need to come in and see us for a follow-up, that sort of thing. There's another group in syndromic surveillance, they have a system, Essence, and they are also an ENS subscriber, and they're receiving real-time inpatient data from the ENS hospital data sources, and that helps supplement their emergency room feeds to improve overall surveillance. Then probably one more big one would be the brain and spinal cord injury program. They're an ENS subscriber, and they use that to alert the case managers when existing patients have hospital or EHR encounters. And again, it's to initiate that patient outreach. Now, they're also a Smart Alert subscriber, the Brain and Spinal Cord Injury Program there. And they use that, they leverage the ENS Smart Alerts using ICD-10 codes and some other criteria to help, again, to initiate that patient outreach to patients who they think could benefit from the Brain and Spinal Cord Injury Program type services. So I think more than anything, we're using ENS to drive outreach, although the various programs are going to use it slightly differently to meet that end goal.
I do want to jump in real quick for those on that are listening that are going, okay, what is a Smart Alert? You've explained to me what the encounter notification service is, but what is this Smart Alert you're talking about? I haven't heard of that. And so just for context, a Smart Alert is actually an ENS notification, but it is, for lack of a better term, narrowed down to specific information. So the Brain and Spinal Cord Injury Program has said, we need to get information on these particular diagnoses. So those diagnoses that would show that a spinal cord injury has occurred or brain trauma has occurred, and they would get those notifications so that they can reach out to patients and see how they can assist them in moving forward and in providing as much assistance as they can to that individual. So, so that's an example of a Smart Alert. There's several others that subscribers to the Encounter Notification Service use. So just wanted to give that context.
What is just really interesting, and even though, you know, I work with this every day, it's just really cool to hear all of the different ways that even just one organization is using ENS services. So I always just find it very interesting how people use it.
I mean, Michael, you just gave us several different examples of how different entities within the Department of Health are using the Florida HIE services, in particular, the Encounter Notification Service. And I know you're doing, you know, a lot, you know, with health information exchange and interoperability, and just a lot with health IT advancement within Florida Health, and different programs are taking advantage of technology. So can you share with us a little bit about why you think it's important that you guys are doing that?
Sure. Well, I think, you know, first and foremost, our patients are like any other. They have an expectation that we're going to keep pace with the industry. So it's important to us to invest in health IT because our patients really demand it. You know, it's like we said early on, it's moved to an expectation these days, and our patients are no different. They have that expectation as well. Secondly, though, there's an opportunity cost to not doing it. And, you know, we all know of the financial benefits of the meaningful use and promoting interoperability program from a revenue perspective. You know, but we need to deliver services that are similar to what our patients can get on the open market. They're not going to come to the health department if they don't feel that they're getting the same quality of care. And certainly our patients want electronic access. They want to be able to communicate securely and directly with their providers if they have a question. These things have become expectations now, and they're really no longer nice to have. So if we want to keep pace, we need to do those sort of things so that, you know, we're comparing apples to apples. So, you know, I can get that service from the county health department. Yes, so when they have a patient portal, yes, I can securely communicate with my provider. They can share my records electronically. You know, those are all the types of things that we want our patients to be able to say when they're talking about the services that they provide from the county health department. Now, our participation in that health IT space has really opened up numerous opportunities for us, I'd say, with, you know, collaboration with the vendors that we do business with. In many cases, these vendors serve as partners. You know, we've significantly invested in integrating their products with our products, our tools. And so we want to see we want to see that that's a good investment, something that doesn't need to be replaced or refreshed anytime soon. And to do that, it's in the vendor's best interests to expand on their product lines in ways that will support the goals of the department. And if we undertake these as partnerships rather than a vendor-customer relationship, we have a lot better success in the end. Our vendors are able to show that, hey, we did something sort of novel with the Department of Health, and look at the benefits they're getting. They can turn around and sell that to others, or just from a PR perspective, it's positive to the vendors. And really, I see that trend continuing. I don't think that it's going to slow down anytime soon. If anything, the pace may get a little bit more rapid in the next couple of years as the technology solutions catch up with what everybody's thinking. In the early days of certification, there was a lot of gnashing of teeth at certain requirements. Why is this there? What are they going to use that for? I don't see that of being of value. And it was that way in the beginning because some of these things were sort of forward thinking. Okay, well, if we make the EHR do this, then eventually when we have this, we'll be able to use that. Well, not everybody was able to see that far down the road. And there certainly were times that, requirements and things like that had to be revisited in health IT because they weren't meeting the goals initially. But, taking it further, I think, projects like telehealth are in the works, and an expansion of telehealth are in the works of the department. And, that's going with the current situation, the time couldn't be better for something like a remote engagement with your patient, contactless service delivery. It fits right in with the current situation we're having. But again, it's someplace that the industry is going, and so the department needs to go there. Now, not to get on telehealth for too much, but I talked about how we're a slice of the pie in a lot of cases for a patient's full care. Some of the services that we provide, especially when it gets into the realm of HIV prevention and care, they're unique, and patients can't just go anywhere and find these services. And so it's made it so using telehealth so that we can extend the outreach of these services to places that maybe they aren't close to, the Calhoun County Health Department, but they want to get a service from them. Well, they can do it now via telehealth, even if they're in a neighboring county. And not to mention not having to travel and all that. That's all a good thing. But on more of a practice management perspective, our clients have an expectation that the billing processes are going to be similar to other medical providers that they have. And so we're striving in that area too to sort of modernize what we do, make more information available, future projects like being able to accept online payments and things like that. They're things that the industry is doing. And so to keep pace, we need to do that because we need to be on par with what our clients can expect for health services, no matter where they go, whether it's the county health department or they go to their local provider. We want them to see that they're able to get a similar service.
So Pam and I talk a lot about healthcare consumerism and the patient expectations and just how it really has evolved, even in the last year. Since the pandemic, the expectation that I can pick up the phone or look at my computer and have a health visit. So how do you think these health IT initiatives have helped your provider base and be more of that community partner with your physicians and nurse practitioners providing services? Are they, what has their experience been?
That's a really interesting question. If you look at 10 to 12 years of HIE, it's pretty similar. And if you look at how people looked at HIE when it first was proposed versus how it is now, I'm saying it's pretty similar. Because I think in the beginning, our health IT initiatives were seen as like disruptive forces to the county health departments. Because in a lot of ways, they had to change their workflows. They had to change the way they're doing business. Now, certainly, the best software models the workflow, The user doesn't necessarily have to change what they're doing. But this was more for, pushing providers out of their comfort zone, giving up that paper and pen, that cardboard chart needs to get filed away for good, go electronic. It was a struggle. And I would say now EHR adoption is no longer a goal. It's a reality. We have adopted an EHR. Now our focus really is in the workflow design and redesign. We need to make sure that the health IT solutions that we are building work seamlessly for our providers. It should not be an impediment. For example, the EHR shouldn't impede communication and face-to-face interaction with the patient. We don't want them spending so much time documenting in this electronic system for that. And our providers are adamant that we need to stay away from this. And anytime we do things that appear as if, wait a second, you're getting in the way, they let us know. But also, this goal is to capture the client's health record in a way that's consistent, standardized, and shareable. And to do that, certainly there's going to be a learning curve. And it may require more effort if you're doing more detailed documentation than you were in the past. And as we begin to make that data more available to the community partners, I think you're going to see more and more opportunities for collaboration to open up. We've had some small programs where doing things like providing electronic blood pressure monitoring devices out to counties that have blood pressure monitoring programs so that they can partner with the local YMCA to be able to provide that tutoring services on how to adequately monitor your blood pressure, and then connecting that to our patient portal so that that data can flow from those devices via Bluetooth, and then we can make that data available to all of our providers. Because if I'm monitoring your blood pressure and you come in to see me once every 6 months, take your blood pressure, it's not very valuable to me. Well, if I can get you to measure your blood pressure twice a day and I can trend that on a graph, I can get a much better idea of how we need to manage your blood pressure spikes and dips and things like that. So, I think our community partners really see the ability to access that FDOH data as essential now, because like we said, you wouldn't have the total picture of a patient's health without it.
Yeah, and it's really good to see you guys utilizing the community partners to get that full picture and find out what's going on with the patient over time. So it's really exciting to see that, and in building those relationships, because we all know it's about not only just the technological ability to connect, but that relationship and wanting to connect with each other and share information. And as we think about that and we look at connecting and sharing information, can you share with us some of the barriers that maybe you've heard about or that you've seen in community providers in Florida Health in connecting and working together?
Mm-hmm. Sure. I think probably the first barrier would be awareness. There's numerous opportunities to connect to the department systems. The PDMP and Florida Shots are two perfect examples of systems where you can connect to them electronically now using modern technologies. Not everyone's aware of that. But the second hurdle is probably technical preparedness. Because not all providers out there have a partner relationship with their health IT vendors. I mean, let's just put it out there. Not all EHR vendors are invested in their customer in a way that, I can go to my EHR vendor and say, hey, there's this new service offered by the Florida HIE called ENS. Can you hook it up so that we can send them ADT messages?
Yeah.
Sure we can. That'll be a change order, and it'll be about 9 months until we can get that into our product backlog. And that's what a lot of these providers are dealing with. not to mention that they don't necessarily have the technical awareness of it themselves. And, you know, maybe they don't have an IT department that can handle something like, interoperability and using web services and APIs to communicate information back and forth between systems. So I think if you're not technically prepared both personally and with your vendors, there might be some fear towards it. Whereas, this is something that's going to cost me a lot of money. It's going to be a road I don't want to go down. I just general fear about proceeding into the unknown. But with that being said, the department does still want to strive to make connecting less burdensome. And we offer a host of services, from things that are more modern like web services to even less technical solutions, more file transfer based solutions. So I think what the best thing is that if someone has the desire to connect with the department, they should engage with somebody within a given program. They can go out to floridahealth.gov. That's our main website. And that has connections where you can find contact information with every program at DOH. And just start the conversation and find out. I do know that the manual processes can be costly for some of these providers, whether it's submitting, reportable lab results or, submitting data to Florida Shots. If you're doing it manually, it's probably much more costly. Now they'll have to make an investment up front.
So again, if somebody does have questions about how to connect, the programs you offer, that sort of thing, just the general Florida FDOH website is a good place to go?
Yeah, the floridahealth.gov is the best place to go. And when you go in there, you can go under About the Department and you can look at all of the various divisions. Just because there's so many opportunities out there to connect with us for one reason or another. You would need to work with that individual department to find out the specifics about how to go about that.
Okay. And I'm gonna put you on the spot with this question. So how many patients do y'all serve a year? Do you have any idea?
1 million.
A million.
Yeah, we have about a million visits a year. So our volume's pretty high. As we had talked, family planning, STD, HIV services, those are really high. Some numbers for you to give you perspective. Family planning during the last year, now, was somewhat impacted by the COVID situation. We had over 760,000 services, family planning services provided. Dental is something not a lot of people know about, but the department provides dental care to the youth population. We had over 800,000 dental services provided last year. HIV, immunizations, those are both over 600,000 each themselves. Now on the primary care, we're not doing as much as we used to, but we do. If you look at comprehensive adult services and comprehensive child services, it's almost 1.5 million services last year provided in those comprehensive categories. So yes, we don't do nearly the primary care that we used to, but we're still very much a player in that space.
And that really kind of reiterates the need to be able to share that data and share that information, because you are a piece of that healthcare, right? And partnering with a lot of other community providers.
One question, you're talking about Florida Shots and immunizations. We get this question a lot in the Promoting Interoperability program is, well, I don't do shots, or I don't see children, I don't do anything. But when we talk about Florida Shots immunizations, we're not talking about just those child immunizations. We're talking about flu shots, all of it. I assume the COVID vaccines is going to be part of that. So it really is a comprehensive across all ages. So keep that in mind too as you're thinking about, I don't need to connect with Florida Shots, but yeah, it's more than just those measles and rubella. Is that what you call it? Rubella?
MMR.
MMR.
Mumps and rubella.
Yeah.
That's the easy way to say it. MMR.
Yeah. MMR. All right. So Pam, let's get our questions.
Okay. We have some questions about the standards for sharing data and I guess the security protocols that are in place for data that is being transmitted, and how are you ensured that the data being sent across these systems and out of your EHR are safe?
Sure. That's an area that's very near and dear to the heart of Florida Department of Health. And that's because we have some very, very, very sensitive data. Certainly no one wants to have their HIV status or the care that they're receiving shared with anyone. That's probably the most sensitive information that we have. And then the most risk to the patient if that data were exposed. So, believe it or not, the Department of Health's data security policies are more strict in the state of Florida. So we often have challenges where we'll work with a vendor and say, well, yeah, I know all your other customers can do it like that, but we're the Department of Health and we cannot do that. So there's very strict policies that govern the sharing of any data. Our data use agreements are very, very detailed if data is going to be shared outside the department for any purpose. And so when we look at vendors, often we're looking for vendors that are not learning about data security, but those that are leaders in that data security realm, and those that have the certifications and things like that that go with it that let us know, all right, this vendor knows what they're talking about when it comes to data security. Certainly when we're working with HIE, we're partnering with CRISP and Audacious Inquiry. One of the attractive features of CRISP as a vendor was the fact that they support the Maryland HIE in West Virginia and Washington DC and Delaware. So they have a very expansive data center that's also very secure, and they've been doing this for many years. And so that's part of what we look at is how long have they been doing this? Do they have security policies in place that are as strict or stricter than ours? Just to make sure that extending our data to this vendor doesn't mean that it's going to be more vulnerable, because that's certainly not something we want. We want them to be as secure or more secure than we are.
Thank you for that. And another question that we have is around the data being shared through the encounter notification service, Michael. And I guess it's just clarification on whether the county health departments or Department of Health is sharing data as well as receiving data, which they are, correct?
Yeah. It's interesting. We're definitely receiving data. Data consumer was one of the first things that signed us up. But we also saw, of course, it's our data, so we think it's very, very important. We saw value in sharing our data with other people through ENS, and so we, of course, wanted to be a data source as well as a subscriber. Now, from what I understand, due to the nature of our visits and our encounters, they were a little different than the hospital encounters. And so not all of the ENS participants elected to receive alerts from the Department of Health. But all you need to do is contact somebody at ACA or Audacious Inquiry and just let them know, yeah, I want to receive those notifications from the Department of Health as well. I think we have 1 or 2 organizations already that have signed up to be receivers of DOH data, but it's very easy. You just need to contact them and say, hey, yeah, sign me up. I want to be on the list for that. And then our data becomes available through ENS.
Yeah. And I think it was, you talked about the, 1 million patients a year. So I think it was just the volume of data that some providers really couldn't handle. It's like, whoa, that's a lot of information, right?
Yeah, it's the nature of our visits. Generally, they're not emergencies. They may not necessarily be things that follow up as required. A lot of your ENS participants are hospitals. I think about half of them are hospitals and critical access areas. So, I think the nature of the data was part of it. But I think too, as time goes on and we mature this service, and people become more aware of what it can do, that may change. You know, like, here's a quick example. I know we're running short on time, but for the Department of Health, the encounter notification service was new to us. We hadn't used something like this before, although we had some programs in county health departments where they were doing something similar, but a very manual process. By and large, the county health departments didn't know how they were going to use this information initially. And so to integrate, we wanted to come up with a strategy that was, you know, easy for us to do and not requiring a lot of decisions to be made where if we change our mind down the road, we're going to have to bust up some concrete. So what really made that helpful for us was the prompt application. So we went ahead and we set up our ADT feeds to go to the ENS service to populate our panels and also serve as our notifications. But when we receive that information back, rather than trying to integrate it into the EHR and make good decisions about exactly what the workflow is going to be, we instead decided to use that external application prompt so that the notifications flow into there. We set up users with prompt. They can go in there and do some management of the alerts that they get right within there. Now, down the road, another year, 2 years, might we do a tighter integration with the EHR? We may. And it's going to come down to, you know, can we ask the county health departments to consistently tell us what the workflow is that they'd like to see for handling these alerts? And if we've got something consistent, something that we can make electronic and it'll be more efficient, then we'll go ahead and do it. But I think that the challenge for us was asking our users to commit to a workflow for something that they'd never seen before. So that's an excellent option for those that are looking to implement the service, but don't exactly know how they're going to use the information. Maybe don't want to spend a lot of time integrating with their vendor. Use the external application for it in that case, and then that way, all you really need to worry about is the data that's being fed out of your EHR.
And I know Kim and I love to talk about prompt, but for those that don't know what prompt is, it is a user interface that can be used to receive the encounter notification alerts. The ENS can be set up several different ways, so you can receive data several different ways, whether it's through direct secure messaging or this user interface, or integrated into your EHR system. And so there's different complexities and ways that you can receive data from ENS.
So we have 3 minutes. I don't know if we have any other questions, or Michael, if you just kind of want to summarize what your experience has been, what you think's on the horizon, the best thing that's happened, the worst thing that's happened.
The best thing that's happening to us right now is HIE becoming a reality. This is something that we have pursued for many years. We've learned along the way. We've noticed some of those pitfalls, and hopefully we'll avoid them in the future. But I think where we are now is the best spot that we've been yet, and that's as far as where ACA and Department of Health are, as far as collaborating on making HIE a reality for the Florida Department of Health and the county health departments. I think that's the absolute best thing that we've got going, I would say.
Well, we will take that plug and we will reciprocate that with the Department of Health. So how about that? We really do appreciate all the work that you guys are doing.
And it's all becoming a reality. That's what's so cool about it. It's all finally happening.
Yeah, it's really exciting. It's really exciting. And speaking of exciting, for those that are here on this Health IT Matters episode today, I want to make sure that we let you know that we are going to be doing these every month. So the third Thursday of every month at 1 o'clock, you can join us for the live episode of Health IT Matters, or you can catch it in the recorded version. So you have your choice there. If you can't make it to 1, you can always catch the recorded version. But we definitely like to have you live so we can get these great questions and talk about what's happening from different perspectives Next month, we are going to be talking about telehealth. So I thank Michael for doing the little telehealth plug for us earlier and what they're doing at the Department of Health. And so we're going to be talking about telehealth a little bit more and talking about the impact that the pandemic has had on telehealth and where we think we're going in the future. So real excited about that one.
Thank you everyone for joining us. I hope that today's Health IT discussion has given you an idea of what's happening in Florida. The Agency for Healthcare Administration continues to support Health IT to enhance its mission of better healthcare for all Floridians. You can stay up to date with podcast episodes and all other agency-related news through our social media pages on Twitter at Florida_ACA, on Facebook at the Florida Agency for Healthcare Administration, and we're also on LinkedIn. So until next time, I'm Corinne Slaughterback. This is Health IT Matters. Thank you everyone for joining us.